In the center theriyada. Okay. Good afternoon to one and all. Greetings from Chennai Apollo Hospitals. My name is Dr. Ravichandran, a senior consultant in the Department of Dermatology. I would like to begin my topic today. The topic of choice I have taken is what's new in dermatology. I will go through a set of slides so that it is very useful topic for the practicing dermatologist as well as for the postgraduate and undergraduate students. Dermatology is a very fast developing field, and new techniques, new innovations, new therapeutic drugs are available in the market all over the world, and new developments which happens in most of the departments in the field of medicine has also done with the dermatology section. I thought probably I will cover up this topic in 15 slides so that we can exchange our views, and then maybe we can interact at the end of the program. Question and answer session is there. So we broadly divide this topic into 5 sections. Clinical dermatology is the sheet anchor in any dermatology practice. The next one is pediatric dermatology, a vast developing field. The most sought after now in the world, particularly from the Western literature, it has come to the developing nations like us, aesthetic dermatology, otherwise called the cosmetic dermatology. People want to look good, people want to be very aesthetically placed, and it gives a lot of immense self-confidence, and then people want hair done, hair removed, face redone, liposuction, breast augmentation, hair transplantation. So I would like to address this topic of aesthetic dermatology when I go to the next slides. Dermatological surgery, one of the best fast advancing field, where it's a branch of plastic surgery where dermatologists, skin specialists have a role to play by simple techniques. Most of them are office based procedures, less time consuming, and it is usually done in day surgery centers. We here at Apollo Hospitals do this in the day surgery unit departments, which is placed in the city limits, within city limits. Oncology, we are talking about cutaneous oncology here. In Western literature, the melanoma is the big concern, particularly in Australia and United States and UK, where light-skinned people develop skin cancers, probably related to the gene as well as the environmental factors have a role to play. The common environmental role findings here, the ultraviolet ray exposure, particularly the UVB spectrum of UV radiation, which causes squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. Clinical dermatology is very interesting that in our practice we see 30% of patients with infective conditions, particularly bacterial, viral, fungal, treponemal, and other infections. Tuberculosis is very common here in India and other developing countries, and say so the immunosuppressive disorders like HIV, particularly AIDS complex. We have a lot of finding skin lesions which occur in patients who are immunocompromised, particularly acquired immunodeficiency syndrome. So in the previous lectures which I had addressed through the same Pan-African meet, I had shared my topic on the common skin problems and another one on infections, maybe a few months or few years ago. Coming to the clinical dermatology section, there is a lot of developments have happened, particularly in the autoimmune and systemic disorders. Biologicals have come to the market, and it's one of the best discovery in the world, and the disease management, the prognosis have all changed because of the advent of these biologicals. We have you have these MABs, we call these monoclonal antibodies, which are used for many number of conditions, particularly for connective tissue disorders like rheumatoid arthritis, psoriasis and psoriatic arthritis, immunobullous disorders like pemphigus group, drug eruptions, bone marrow transplant units use biologicals in a big way. And just to cite one of the references from this literature, chronic idiopathic urticaria, which is generally difficult to treat and the patients find no answer because we've been using lots of antihistamines and steroids, but where does we stand? This condition generally recurs with severity, and itchy articarial wheals are there in generalized. They don't respond to most of the time. Patients are developing side effects to systemic steroids drug therapy. So one of the MABs called the monoclonal antibody called Omalizumab is one of the upcoming drug which is a monoclonal antibody IgE, has shown promise in several types of chronic urticaria. We define them into acute and chronic. Chronic urticaria is one which remains for more than 6 weeks duration. We try to identify the factors involved, and we have one segment called autoimmune urticaria. We identify this disease by doing a small autologous serum testing. We take a small amount of patient serum and inject intradermally and identify whether wheal and flare formation occurs. Then these patients are advised to continue their steroid treatment. But how long to continue? So when you in these situations, these monoclonal antibodies, particularly Omalizumab, it is available in the world, available in our country too, that it is one of the best options for patients who develop this difficult dermatosis. Another monoclonal antibody I was talking about to you is this biologicals, Rituximab, called MabThera, which is world over. It's really given a boon to the pemphigus patients. Pemphigus is an autoimmune bullous disorder wherein we have different types of pemphigus. This pemphigus vulgaris, which is commonly seen, is a life-threatening acute immunobullous disorder affecting humans. It is directed against the antigen called the pemphigus antigen. Antibodies are produced called desmoglin and placoglobulin. So these antibodies react with the antigen called the intercellular cement substance, and the patients develop large blisters called flaccid bullae, erosions. Oral lesions are to begin with. They develop oral lesions, extensive erosions and skin, including upper 1/3 of esophagus, where if you do not identify and treat these patients, there is a possibility of a mortality. So there is high mortality in pemphigus group if you do not start the treatment. The conventional treatment all these years we've been using is the steroid, which is the sheet anchor. But patients who do not respond to steroid therapy and patients who are refractory to treatment, and to come out as a crisis buster and to give a long-term remission and try to remove the antibodies against this pemphigus antigen, Rituximab plays a major role. It is called MabThera. In the largest prospective study to evaluate the treatment of pemphigus with Rituximab, 42 patients with severe refractory pemphigus vulgaris and pemphigus foliaceus were treated with Rituximab and prednisone. After 6 months, complete remission was achieved. That we defined as an absence of new or established lesions occurred in 36%. 86% of patients showed a very good remission, including 29 patients who had complete remission for at least 2 months after treatment was stopped. That's a very good news. And 7 patients who required minimal therapy also. That means we reduced the dosage of conventional steroid therapy along with other immunosuppressives like cyclophosphamide, azathioprine and methotrexate. So this is we have started using it in our Apollo hospitals, and most of the centers in the western countries are using this as a drug of choice, particularly as a second line of therapy. Cutaneous sarcoidosis. Of course, systemic sarcoidosis is a very difficult condition, and patients develop fever, weight loss, and mediastinal lymphadenopathy. And those patients who have this sarcoidosis, systemic sarcoidosis, also develop cutaneous lesions in the form of papules, plaques, and nodules. And these patients are treated with steroids. Again, steroid is a life-saving treatment for sarcoidosis. Biologicals have again come to play in a major way in the management of systemic sarcoidosis. We also use topical calcineurin inhibitors like tacrolimus and pimecrolimus for cutaneous lesions of sarcoidosis. Adalimumab, which is a new biologicals, like again another monoclonal antibody. A trial found a statistically non-significant difference in the physician global assessment score. 5 of 10 patients in the Adalimumab group versus 1 to 5 patients in the placebo group achieved at least a 2-grade improvement. So sarcoid patients can hope for another alternative drug in the form of a monoclonal antibody. Atopic dermatitis, which is commonly associated with the atopic march disease like allergic rhinitis, hay fever, bronchial asthma, urticaria, is a very difficult condition which affects the newborn, called the infantile atopic dermatitis, childhood atopic dermatitis, and adult variant, which is generally acquired through IgE mediated genetic condition called extrinsic atopic diathesis, wherein their IgE level is very high. Patients also develop hypereosinophilia. These patients start a lot of itch, and they have the commonest finding is the itch, which leads to the scratch, the itch scratch cycle. The atopic march and the itch scratch cycle are the hallmark of atopic dermatitis. We give topical emollients, barrier maintenance, barrier creams, topical steroids, antibiotics, topical antibiotics, as well as calcineurin inhibitors. Though there are black box warnings for the use of topical tacrolimus and pimecrolimus according to the FDA, but now it has been approved for the use of mild to moderate atopic dermatitis, both topical tacrolimus and systemic steroids if the patients get into the severe type. The one recent one is called the evening primrose oil or borage oil for atopic dermatitis. The 2012 European and American guidelines for the treatment of atopic dermatitis recommend proactive intermittent topical therapy, including this topical application of the evening primrose oil. We start using topical guidelines says that we use the topical steroids and then antihistamines, and subsequently we maintain them with topical tacrolimus or pimecrolimus along with definitely an antihistamine to prevent the itch. Antibiotics are also very useful because of the bacterial flora. Staph aureus infection is very common in atopic dermatitis patient. Coming to the aspect of infections and infestations, as a dermatologist we use plenty of azithromycin for cutaneous infections. It is one of the drug of choice for the treatment of acne vulgaris. We give azithromycin as a pulse dosing in the management of acne vulgaris. And now it's been linked. Remember, we had an issue earlier about macrolides and cardiovascular toxicity. Azithromycins also can have an impact on the cardiovascular mortality. So we have to be very careful, particularly in patients who gives a cardiac history, symptoms of cardiac abnormality with cardiac medications. It is better to avoid azithromycin. Another one called the tesolonide, where is a novel oxazolidine drug that is non-inferior to linezolid. Linezolid is a very good antibiotic which is very useful for patients who develop MRSA, that's called methicillin resistant Staph aureus, in the treatment of acute bacterial skin and soft tissue infection, and it's in the promising results have been done after a clinical response, so they are very good drug similar to your linezolid. Topical ivermectin for pediculosis capitis, another new development. Of course, scabies and pediculosis is one of the parasitic disorder which is very commonly seen in the developing countries, particularly in the lower socioeconomic group of patients, where we give systemic ivermectin as a single dosage, 6 milligram per kilogram body weight of ivermectin in 2 doses, so that the patients develop a good clearance rate in extensive scabies and pediculosis. We've been using topical permethrin as well as topical gamma benzene hexachloride lotion for the use of treatment of pediculosis capitis. Now this is a new topical ivermectin. It's just a wash, we just apply on the scalp, hair and the body where you have it in pediculosis capitis, pubis and corporis. Just leave on lotion for a few minutes and then we get a good result. So this is topical ivermectin, the new agent. Psoriasis and other papillosquamous disorders. World over, there is highest incidence of psoriasis. We know that psoriasis is a chronic immune disorder where it's mediated by the T cell, where now of recent advances have shown that psoriasis is a very difficult condition, often associated with comorbid conditions in the form of obesity, liver disease, particularly fatty liver, coronary artery disease, hyperlipidemia, smoking, arthritis as well as hyperlipidemia. So when you talk about comorbidity, patients who also develop coronary artery disease because of the inflammatory pathology, because of the interleukin generation from these patients. So any patients who develop psoriasis needs now we always use a biological in the form of Remapcade or Enbrel, Infliximab and Etanercept. Of course, when you give Infliximab, we do take precautions, particularly the anaphylactic reactions which occur as infusion-related reactions, but we always give a dose of hydrocortisone before we initiate these patients on this program. And we always strictly follow the guidelines when we use these biologicals in patients with extensive refractory psoriasis. The concern is his reactivation of latent tuberculosis. Tuberculosis is a very important infective agent, particularly in developing countries. So patients who can develop a reactivation of the latent or unacquired tuberculosis infections when these patients are put on these biologicals. So we have set guidelines, we monitor them, but it is one of the best options in controlling a quick disease remission as well as the prolongation of a disease-free period. So Infliximab is available world over. Infantile hemangiomas is a baby with a large hemangioma, particularly strawberry hemangioma, port wine stain. These hemangiomas can occur at different sites, particularly eyelids and oral mucosa, anal perianal area, where it interferes with the normal functions. Babies born with a large hemangioma and the eyelid and the forehead can occlude the vision so that they might develop an amblyopia. To prevent that, because we have to start treating them, because surgery is not very it's a last resort, so we always prefer topical steroids, intralesional steroids, but you know the side effects of these steroids. So the new agent which we call this as Inderal, which is given as an antihypertensive drug called propranolol, is being shown promising results including children, babies and with hemangioma. Based on multiple observational studies, propranolol has been adopted as a first-line treatment for infantile hemangiomas that have potential to improve vital functions or cause disfigurement. And for ulcerated hemangiomas also they do a very good clearance rate that may cause permanent disfigurement, which can interfere with the daily life activities or do not respond to wound care measures, so they ulcerate and they don't heal. So in those kind of situations, there's a small trial going on with our hospital that we can try topical propranolol, but systemic propranolol is the drug of choice for patients who have an extensive, particularly from the pediatric segment. Move on to cosmetic and surgical dermatology. Use of sunscreens, daily use of sunscreens to prevent skin aging. I was talking to you initially that skin cancers are triggered by chronic photo damage, and particularly patients who have got a lighter skin type develop features of skin cancers. The life-threatening skin cancers is melanoma, so the black cancer. So always we have to be very careful in picking up these patients at the early stages. Daily use of sunscreen to prevent skin aging. We suggest daily use of broad spectrum sunscreens with an SPF at least 15 plus for young and mid-aged individuals who desire to slow the photoaging of their skin, and particularly for those with light skin who live on the areas with high levels of solar radiation. And of course this is also one of the good options who have patients who have photosensitive disorders, particularly polymorphous light eruption, systemic lupus erythematosus, cutaneous lupus erythematosus, photosensitivity, chronic actinic dermatitis. All these patients also benefit from the use of sunscreen. Protection is given nicely. I was again mentioning how these biologicals is going to revolutionize our therapy in the future, and Adalimumab for hidradenitis suppurativa. Hidradenitis suppurativa is a common, difficult, painful disorder affecting the apocrine gland. It's affecting the oil. It's like acne which affects the sebaceous gland. Hidradenitis suppurativa is one which occurs at the axilla and the perineal area, where the sen glands are inflamed, and then the secondary infection starts. Patients suffer from pain for years with lots of discharge of pus and scarring. A new randomized trial of 154 adults with moderate to severe hidradenitis suppurativa compared the efficacy of two regimens of Adalimumab to placebo. The trial found that patients treated with once weekly dose of Adalimumab for 16 weeks were most likely to achieve a clinical response than patients in the placebo group. That initiates that this is one of the future drugs for patients who develop hidradenitis suppurativa. What's new in cosmetic dermatology? Botox came to the market. It's still one of the best agent for reversing your age. A lady who is 60 years can look like a 30-year-old lady by masking all the skin lines, the frown lines, the hanging fields, the neck folds. Botox is botulinum toxin A, which is used for the rejuvenation of upper and lower mid-face, including the neck rejuvenation. A two-pronged approach, particularly using hyaluronic acid filler like Restylane or Juvederm, which is a volumizer, to fill the pocket along with Sculptra. These are all very amazing good results are achieved to lift the top of the nasolabial fold and restore the position of the nose. Fillers, the semi-permanent fillers, botulinum toxin, have a role to play because of this. It's less invasive than a facelift surgery or a thread or a bead surgery. Skin care. People want their scalp hairs not to fall. Skin do not want to wrinkle. They don't want to age, show signs of aging. So to reverse all these things, use of sunscreen I was telling you, and now we have antioxidants, both topical and systemic. We have peptides, decapeptides, which reverses the aging by producing new collagen, and lots of growth factors are available in the market, where centers like cosmetic centers use this for all these indications. One such new technique is called the platelet-rich plasma in facial rejuvenation, acne, treatment of acne scars, and treatment of diffuse hair loss. PRP, otherwise called, is very easy, simple technique. We take 10 ml of the patient's venous blood and let it allow to clot, and take the serum and centrifuge it, and then prepare the buffy coat and take it in a small syringe and inject it subdermally, particularly into the dermis, into the hair, scalp hair, or you wanted to rejuvenate the facial skin. It is also very much useful in the sports injuries, in the orthopedics and other areas. So we have, in the world over, we have also started using this PRP technique in our hospital. Laser innovations. Lasers are wonderful tool wherein the thermal energy used for cutting, freezing and rejuvenation. Fractionated lasers create a pattern of microscopic injuries to the skin known as microthermal zones of injury that stimulate collagen production. Fractional carbon dioxide lasers, fractional erbium-YAG lasers are most sought after, and they give a very good lift for the facial scars, facial rejuvenation. Another way to boost the results of laser resurfacing is through application of a PRP I was just mentioning you. Though dermatological studies are still in their infancy, PRP has roots in orthopedics and sports medicine, where it has been used to speed up the healing of wounded tissue, in particularly athletes. So this is, we dermatologists and cosmetic surgeons have found a new method by which we can give some better results in a short time. Lasers, we have the lasers for facial rejuvenation, lasers for hair removal, particularly we have the diode as well as long pulse Nd:YAG. We have lasers for pigmented lesions like caffeole macules or port vein stain, pulse dye lasers, Q60 Nd:YAG, fractional CO2, the erbium-YAG, glass erbium-YAG. Mind-boggling. Every day we get a new laser machine and the one which is being used becomes obsolete. So there is a market for laser in the future, and it is very useful in the lighter skin individuals, and in patients who have got Asian skin. These patients also benefit with their usage. How do you prepare PRP? PRP is obtained by drawing a small amount of blood, then centrifuging the blood in a test tube to separate the plasma from the red cells. The plasma contains high concentration of platelets, which can be painted on the skin after fractional laser treatment. Very simple technique to encourage healing, or injected to the skin just below the dermis, I was just telling you. And while the results are very anecdotal, many patients have reported marked improvement in the skin rejuvenation and reduction of acne scarring after the procedure. There is a question of this in the hair rejuvenation particularly, but there are equivocal results. Some centers say it is not a good drug option, and some people claim that PRP rejuvenates the hair in a good way. Thank you so much for patient listening. Have a good day. Bye.